So, welcome to the What's New in Lung Cancer webinar series. My name is Paul Wheatley-Price. I'm a medical oncologist in Ottawa, and I'm currently the president of Lung Cancer Canada. And this is number 2 in the series. We had our first one about a month ago, which was called What's New in EGFR Lung Cancer with Dr. Barb Malosky and Professor Tony Mock. And today we're going to be talking about what's new in ALK lung cancer. And you can see on the screen the panel, Dr. Ross Camidge, who is a medical oncologist at the University of Colorado and is the lead author and investigator on a number of important ALK lung cancer clinical trials, and Professor Natasha Leighl, who is professor of medicine at the University of Toronto at Princess Margaret Hospital. She was the chair of or co-chair of the World Conference on Lung Cancer a couple of years ago in Toronto. Also an expert in ALK-positive lung cancer. You can also see this as a podcast. This will be going out on the Lung Cancer Voices podcast, which you can get through the Lung Cancer Canada website or from your favorite podcast provider if you listen to podcasts. And in fact, there's one just released today with Dr. Kevin Zhao about his experiences dealing with COVID and lung cancer in Montreal this year. We're going to spend about 45 minutes going through ALK lung cancer as a sort of moderated discussion. I'll be doing a kind of interview format with Ross and Natasha, and then we're going to try and leave at least 15 minutes at the end for questions. So if you do have questions that you already have or come up as you're listening, if you go to the bottom of the page on the Zoom page, and you'll see Q&A or chat, you can put your questions in either of those, and Christina Sitt from the Lung Cancer Canada team will then moderate a question session at the end. So with all of that out of the way, let's get into this. And Dr. Camidge, Ross, I'm going to come to you first in Colorado, and maybe you could just give us the sort of Coles Notes entry level view of ALK lung cancer. What is ALK lung cancer? How is it different from other lung cancers? Could you start with that?
Yeah, so ALK stands for anaplastic lymphoma kinase. And as its name suggested, this was a gene that was discovered in a disease. It was discovered in a type of lymphoma, kind of blood cancer. And people kind of ignored it for 10 or so years until it was found to have a role in lung cancer in about 2007. So one of the interesting things is, because it was discovered as part of a disease, the normal function of ALK hadn't really been well described, and it's sort of been playing catch up. We believe its normal function is in the development of the embryo, in the gut and the nervous system, although there's a little recent data to actually challenge that. But then in most tissues, it's turned off. Its promoter, the thing that starts it off, its starter motor, is silenced. But in some cancer cells, they essentially get somebody else's starter motor that sits in front of it and starts it off running. And now it isn't just, telling you to develop organ systems, it turns them into a cancer cell. And that's about, excuse me, that's about 4% of lung cancer.
And is this a completely unique subset of lung cancer, or can you have this alongside some of the other subtypes of lung cancer that we've learned about, like EGFR or other types?
So when you walk through the door, this kind of lung cancer, which is the first example of what's called a gene rearranged lung cancer. So it's not a mutation. It's, you take a gene that's silent and you bring in another gene that's got the starter motor that gets it going. There's now some other things in that family, ALK, ROS, RET, and NTRK, the other ones, in decreasing order of frequency. But these things are all mutually exclusive when you walk through the door. Interestingly enough, that rule gets broken if you start to perturb things by coming in with specific inhibitors, because it turns out that anything that can drive a cancer can actually come in a supporting role later as a mechanism for acquired resistance. But in terms of, if you walk through the door and somebody says you're ALK positive, you don't need to go looking for an EGFR mutation, or vice versa. Okay.
And one final question for you, Ross, before I move over to Natasha. Is there a particular type of person who might get ALK lung cancer? Is if we lined up ALK lung cancer people in one room and everybody else with lung cancer in another room, do those rooms look the same?
So that's a great question. So the answer is yes, and then a word of caution. So yes, they are more likely to be younger than people with, you know, your common or garden lung cancer. They are more likely to have no smoking history or very light smoking history. There's no particular age predisposition. There's no particular race predisposition. But here's the word of caution. These things are, you know, games that you play in the clinic to say, oh, here is a, you know, 35-year-old man or a, 35-year-old woman who's never smoked, and, you know, they have a particular pattern of spread. Maybe they're going to be ALK positive. But that's not a substitute for testing. And the other one is, even if you're a 85-year-old man who smoked, I would still test you for ALK, because the only thing that changes is the frequency of positivity, which changes the health economics. But if it was your mom or your dad, I'd still test them.
Right. Yes, and I think in my practice, I have 20-year-olds, 60-year-olds, and 80-year-olds with ALK lung cancer in my practice. Okay, so thank you for that. So that's the kind of basic introduction. I like your starter motor analogy. I've not heard that before. Right, Dr. Leighl. So tell us, how do you treat ALK lung cancer, and how do you do that differently than you would a different type of cancer?
Well, thanks, Paul. So what's been very interesting about ALK is it's really the second group. People with ALK positive lung cancer are the second group of people with lung cancer where we found tablets or targeted therapies that work much better than chemotherapy. And since about 2015 in Canada, we've been able to use a drug called crazotinib. It was the first of the targeted therapies for people with ALK positive lung cancer. But currently in Canada, we have at least 3 approved drugs, 3 approved tablets as initial therapy, or the first type of therapy somebody could have if they had ALK positive lung cancer that spread to other organs, or what we call stage 4 disease. And the one that we most commonly use is the most recent one that's been approved, which is called electanib. However, in the literature and, you know, things that Dr. Camidge and others have been publishing, there are actually 6 tablets that are potential options. And of course, the challenge is, you know, which tablet is the best and who should have which tablet. And that remains, you know, a real discussion. But currently today, if you were a patient and you had stage 4 ALK positive lung cancer, your oncologist would probably offer you electanib. Currently, crazotinib, ceritinib, and electanib are pretty widely funded across all of the provinces, so almost all the patients get access. Some of the other drugs that are approved but not funded include brigatinib. Dr. Camidge has done a lot of work on brigatinib, and we've been happy to be part of that program as well. And more recently, lorlatinib. These drugs, even though they're approved by Health Canada, which means that they're safe and they work, they're not actually funded through the public system. And these drugs most commonly are approved after the first 3 drugs that I've mentioned, crizotinib, ceritinib, or electanib, stop working as subsequent therapy. Electanib currently is also approved after, for example, crizotinib fails, but I think very few people today are being started on crizotinib. Almost everybody's being started on electanib. You know, when it comes to diagnosis, we've actually been very lucky in Canada. Some of the tests can be very expensive. Lung cancer is a common disease, and you don't want to miss anyone that has ALK positive lung cancer. So Dr. Ming Chow, who's one of our pathologists, actually led the charge, and he developed a fairly simple and inexpensive protein test that has really helped us identify people that will benefit from ALK-targeted therapy. And so that's really our first step in diagnosing this. And of course, there are other ways that are more expensive and certainly evolving to diagnose ALK-positive lung cancer as well. So we currently test almost everyone with advanced lung cancer, something called non-squamous type of lung cancer, which is the most common. So I think, you know, so basically electanib would be our first choice. And then I think we're going to talk a bit later about, you know, what do you do if and when electanib stops working.
So I'm just going to try and recap that, Natasha, because there's a lot of information in there. Oral therapy, they're all tablets. You said in Canada, we've got 3 approved: electanib, crizotinib, which was the first one, and ceritinib. But now we're using electanib as the first option for people newly diagnosed. And could you just maybe touch on why are we doing that? Why are we using electanib first instead of crazotinib or crazotinib or some of the other ones, brigatinib, lorlatinib, and then I think the newest one, instalment? So why electanib?
Thanks, Paul. So, initially the first couple of drugs, crazotinib and ceritinib, were shown to be better than chemotherapy as that first treatment for people with stage 4 disease. And electanib was compared in 2 trials, one out of Japan called the J-ALEX trial, and another called the Alk+ve trial, which apparently was named after Dr. Camidge's daughter. But it really showed that people that got electanib, there she is, there's Alex, very famous there on the screen. But it really showed that electanib was better than the original drug crazotinib in terms of protecting people from cancer spreading to the brain or progressing in the brain, as well as also having some greater effect at protecting people from cancer growing in the body. And so that's why we've really switched almost wholesale to electanib. For people that are out there who are currently on crazotinib and doing well, actually at this point we wouldn't necessarily switch to electanib, because we have shown that some people can do incredibly well on crazotinib. They can go for years on crazotinib, and then they can actually switch to electanib later if crazotinib stops working. So if you are on crazotinib, please don't panic. Always good to have a conversation with your oncologist about whether you should switch to one of these newer drugs. But most people actually, if you're doing well and your cancer's under good control, can stay on it. But our first choice currently in 2020 is electanib for that better control, both in the body and the brain.
Okay, great, thank you. So back to Alex. Alex, the next question's, no, it's just kidding. It's for your dad. Ross, what's the difference between ALK drugs and chemotherapy in terms of people's quality of life and their chance of longer term survival?
Okay, so Alex, could you give me a second here? Okay, thanks. There's only so much I can do with a 8-year-old, soon to be 9-year-old on my lap. So I mean, the pills are obviously much more convenient than chemotherapy. I mean, the chemotherapy isn't horrible, but the quality of life for all of the studies, with the exception of the ceritinib study that compared it to chemotherapy, is always much better with the pill. Ceritinib really struggled with some toxicities, mostly, nausea and diarrhea. Got a little better when they changed the dosing, but actually in its head-to-head study, it actually had a higher rate of severe side effects than the chemotherapy. So that's the exception. For most of the other ones, they're much better tolerated. They're not completely free from side effects, and they vary by the drug. And I don't know if we're going to talk about it now, or maybe we'll talk about it later, but certainly the different side effect profiles between these drugs, these ALK inhibitors, might influence which ones you start with and your choices when you could have A or B or C.
Okay, so in general, ceritinib aside, much easier than chemotherapy, it's more convenient because it's a pill. And what about that survivorship question? How much better are these drugs than traditional chemotherapy in terms of helping people to have their cancer under control for a long time?
Well, I'm glad you brought that up, because one of the things I'm hoping that we're going to go into when we start to talk about the whole spectrum of what you're going to treat people with is, traditionally in oncology, we focused on something called the progression-free survival, the time it takes, on whatever that initial treatment is before your cancer grows. And we focused very much on that, but partly because it was an earlier readout, but also because there wasn't, for many people, by the time your cancer was growing, you could sort of see the writing on the wall. And the great thing about ALK-positive lung cancer is where the PFS is starting to look a lot more like the time to your next treatment decision, as opposed to, is that the death knell ringing? And that becomes very important when we start to think about quality of life on these treatments, because we want maximal time, and it doesn't really matter if you're changing the tools you use it. We want maximal control of cancer and minimal side effects. I've forgotten where I was going with this. Overall survival, I remember now. And the thing is, ALK is actually this very forgiving disease in some people that you can play catch up later. So ironically, in a study that we published last year or the year before with over 100 ALK-positive patients, your overall survival was still pretty awesome. At least in our series, it was, the median, the 50% point was 7 years. for stage 4 cancer. And it didn't matter if you started on chemo or not, because if you started on chemo, you could catch up. The key thing is making sure you have access to these other treatments. So I think when you look at clinical trials where they've shown an overall survival effect, you've got to ask yourself the question, is the access to treatment in later lines the same as what you would have in your own in your own corner of the world? Okay.
Actually, that's a great segue to the next question I had sort of lined up, which is for Natasha. But I'm going to maybe take words you said, Ross, and hopefully not butcher them completely. But you said 7 years in that series that you published. But maybe to put that in context, for stage 4 lung cancer, historically, overall, survival time has been measured in a year or so.
Yeah, the other way, I mean, you can express survival in different ways, but let's say you did something like a landmark analysis. So what, you're diagnosed with stage 4 lung cancer, you feel your world is falling apart. What is your chance that you are going to be alive in 1 year's time? I mean, that's a pretty, black and white endpoint. For general lung cancer, Natasha, I don't quite know what you would be quoting, but maybe 20–30% chance. I mean, it's probably got better with immunotherapy now, but historically that was the rate. For ALK, that's pushing 80+%.
Right. That's a great way of putting it. I think I'm more optimistic than you. I think I bit higher than 20 to 30%.
I'm going by the old-fashioned chemotherapy study. So.
All right, but drastically different. Let's take it from that. Okay, so I'm going to go on to Natasha, because Ross was just saying there that this important feature is you can catch up with having sequences of treatments. So now in Canada, you were saying, and the same here in Ottawa, that our first choice of treatment usually is electanib. So for somebody who's been on electanib for a while, hopefully a long while, but now it's stopped working, what do you do there?
So it's a great question. It's never a question anyone wants to face in clinic, because these are great drugs and they can work for a really long time. But the first question I always ask is, well, where did it stop working? Was it in one part of the body? Was it just in the brain? Is it one spot? Is it something that we maybe could use a completely different kind of therapy for, like radiation, sometimes even surgery? So a completely non-drug based approach. And then there's potentially the option to either continue electanib or not, and that's another discussion. Where you can't use something local, the other question that I ask is, well, why did it stop working? And some nice work from Dr. Camidge and others has shown that there's sort of 3 different groups of people, 3 groups of changes where the electanib, for example, would stop working. So one is that in addition to this Alk fusion or translocation, you get a new change in the gene, a new mutation, something I would call an emergent mutation. Sometimes you can have a couple of mutations or compound mutations. In another group of people, the cancer stops signaling through ALK because we've blocked that pretty well with the electanib, and it starts using another pathway or cancer pathway. And there are a large number of those. EGFR is one of them, MET, many others. And then the third one is, well, we actually haven't figured this out yet, but there's a lot of interest. And so, where compound mutations or there's an emergent mutation, something like lorlatinib or one of the other newer generation inhibitors, I think is very promising and very active. It can still work in the other 2 groups, but the chance of success is a little bit lower. Now, having said that, in Canada, really our options are, after electanib, we really want our patients to continue targeted therapy. So we would offer lorlatinib to almost everybody that we could get it for. There are also clinical trials, for example, or the option to get brigatinib or go on other studies. Now, where we're worried about that or where we think it may not work, we may then talk to people about chemotherapy. Nobody likes the word chemotherapy, but the truth is chemo is a lot better than it used to be when I started, and then when Dr. Camidge started. and it can work incredibly well. You know, I have patients who are on chemotherapy, often gentle chemotherapy, a drug called pemetrexed in particular. They can be on treatment for years and years and years. So chemotherapy, even though nobody likes it, can be an option. So, you know, first, where is it? Can we look after it locally? If we need to switch drugs, you know, is lorlatinib our best choice? Can we get it? Or brigatinib, for example, or going on a trial. You know, one of the challenges we have in Canada is, you know, that question of why has electanib stopped working, and how do we figure that out? So you can have a repeat biopsy of the tumor. We've been really interested in blood tests, something called a liquid biopsy, where we can find some of these gene mutations and other abnormalities that might be driving the cancer. Biopsies, of course, are hard because, you know, they're uncomfortable, they hurt, they can have risk. Liquid biopsies can be great. They don't pick up everything necessarily, but they can be really helpful. They're just a little more challenging to get in the Canadian system. So currently your oncologist would try and enroll you in a free program or a trial, or see what else could be done to get you a liquid biopsy. Also, the science of tailoring treatment it's not perfect, right? So just because I find a mutation doesn't mean 100% lorlatinib is going to work, or, you know, if I don't find it, that, you know, you should have chemo. So it's not perfect yet. You know, after alectinib, we try for another targeted therapy. If not, we would try for chemotherapy.
Okay, so lorlatinib would be your first choice, probably, maybe brigatinib, if not chemotherapy, or maybe you could sequence those. Maybe one more question I think about access to these drugs, and this might, I know I'm throwing you a tough question here because the answer might not necessarily be all that palatable. Lorlatinib and brigatinib are not yet approved in Canada for use after alectinib. And how can you therefore prescribe it?
So Paul, I think it's such an incredible challenge. You know, we know the drug has activity. We know that our patients in other countries can access these drugs, and yet in Canada, you know, it's that much harder. So usually what I do is I reach out to the drug manufacturer. There are a number of compassionate programs. We also look at trials, and we do, and I think oncologists across the country work really hard for our ALK+ patients to make sure that they can get the next, you know, latest and greatest treatment or targeted therapy, despite the fact that it's not currently funded. So that's what we do currently. It's not ideal. You know, what do you do when these programs close, or if your patient's not able to get these therapies? That's very, very challenging. But it's currently the Canadian reality, and I think we're hoping it will change soon.
I think a good thing about the Canadian situation, though, is we are a very collegial group in the lung cancer community, and so it is very frequent that if somebody is running into trouble on a drug, that we'll get on the we'll get on the blower, but that's probably an English phrase, but we get on the phone, and or we get on email to our group across the country to see who has access to a trial or to a new drug. And so, you know, Natasha is currently helping me with a couple of people that I wanted to access a drug which we don't have in Ottawa, but she has in Toronto at the moment, and it could be that it goes the other way around on occasion. And certainly I've been in touch with Ross on a number of occasions for advice or guidance on cases. So it's a very good community for that. Okay, Ross, Natasha, you're in a different healthcare system to us in Colorado, with probably some better things and some things that you don't like as much. What do you do? Are you able to cycle through all of the different ALK drugs, and do you have the same positive opinion about chemotherapy? But don't answer yet about immunotherapy, because I'm going to ask you that as a separate question.
Okay, so what we do in our little kind of, you know, ivory tower is probably somewhat different from what goes on in the community in the USA. And so, you know, just to sort of toot Canada's horn, you know, there are very few general oncologists in Canada, whereas we have, you know, general oncologists in the community who, you know, partly because of the size of the country, but also, you know, there are people who don't want to reduce their opportunities for billing. They want to see every patient that comes through the door. So these people have a very tough job and they have to stay up to speed with everything. In terms of access to drugs, I'm going to get to your question in a second, but in terms of access to drugs, yes, we are the alpha and the omega of access to drugs, in the sense that if you have good insurance, you can get anything on the planet, and if you have no insurance, you can get absolutely nothing. And so we have all of the extremes. And so again, Canada's, this is a long debate over coffee, whether the average in Canada may well be better than these extremes here. But let me tell you what I actually do. So for a period of time, when you had no alternative other than chemotherapy, then it seemed to make sense that, these biopsies were just a luxury. They were kind of a research tool. And, if you found a mutation, you were going to go on to the next ALK inhibitor. And if you didn't, you were still going to try the next ALK inhibitor because your alternative was chemotherapy. That, I think, is now changing. And it's changing for two reasons. So one is there are not all of these next generation ALK inhibitors are equally well tolerated. And so certainly in my hands, ceritinib is the least well tolerated, but then probably lorlatinib. I've had some people who do great on lorlatinib and some people who it's a really difficult drug for them to take. So if I can find a mutation that I know one of the other better tolerated ALK inhibitors will hit, and then I don't need to go to lorlatinib. So that's one aspect. The other is, as Natasha mentioned, one of the other big slices of the pie is where it's nothing to do with turning back on ALK signaling, but we are identifying second driver pathways. And so if you identified that, that would be a rational choice. It's a rule-in test. If I found evidence of MET amplification or MET fusion or MET skip mutation, all of which have been described, I'm going to talk about adding in a MET inhibitor, not just changing ALK inhibitor. So now that we have alternatives, the value of that biopsy, I think, has gone up. But the challenge is, who's going to pay for the biopsy and who's going to do the analysis, and are you doing the right analysis? I think we kind of know what to look for in terms of ALK kinase domain mutations, but these other second drivers, that is definitely a work in progress. And some of the things that are turned on are not picked up just by a standard next generation sequencing assay.
Okay, so I'm just going to take a simple interpretation of that, is that the science is moving on quite quickly in identifying some of these resistance mechanisms that 3 or 4 years ago wouldn't have impacted what we were able to do, but now are. Maybe in the context of a research study, but still there's that option.
Yeah, but I mean, I still think you have the kind of, try it and see approach. But I think we are getting to the point where if we believe personalized medicine matters when you walk through the door to say, your ALK or VEGFR or ROS, it's gone in and out of fashion, but I think it's going to come back into fashion in terms of in the setting of acquired resistance.
Okay. Before I ask you about immunotherapy, which is a question we often get asked about, I just want to mention just a clarification earlier. So in Canada, brigatinib and lorlatinib both do have regulatory approval from Health Canada, which is the body that licenses drugs in Canada. But Health Canada is not the body that says whether a drug should be funded or not. So lorlatinib and brigatinib are available to be prescribed in Canada. The challenge is finding who's going to pay for the drug.
And that's by province? The funding is province by province?
So yes, it's complex, but Health Canada is for the whole nation. And then there is a health technology assessment process called PCODA, Pan-Canadian Oncology Drug Review. And that's for all of Canada except for Quebec, which has its own process called INS. And PCODA and INS will make a recommendation as to whether a drug should be reimbursed. And if it is agreed to be reimbursed, then it goes into a confidential price negotiation that we are not party to. And when that has been agreed, it then goes back to each individual province to fund within their own formulary budget. And so it's unfortunately what that means is there's a postcode effect, that you can live in one postcode and have access to a drug, and if you live in another postal code in another province, you may not, and it may be coming, but there are sometimes time differences.
can I just, is it very restricted to the wording of the label? So let's say brigatinib was approved post crazotinib, you wouldn't be allowed to give it post electanib, even if you knew there was a mutation it was sensitive to?
It varies. Generally, yes, quite well. Electanib, for example, is available as first line or post crazotinib. Because the others haven't gone through the health technology assessment process, it's not yet clear. But I think their Health Canada labels are basically broader.
Okay.
I want to ask Ross, I'm going to ask you about immunotherapy. This is a common question that people have because, you know, the big advances in lung cancer in the last few years have been targeted drugs like the ones we're talking about tonight, but also immunotherapy. Does immunotherapy work in people with ALK lung cancer? No,
at least not as defined by PD-1 or PD-L1 based therapies. There is, in terms of monotherapy, there is zero data that I am aware of anywhere in the world that any ALK positive patient has ever responded to a PD-1 or PD-L1 inhibitor. We also know if you try and combine them with the ALK inhibitors, you can get exaggerated toxicities. There was one study, the so-called IMPAL 150 study, which did include a smattering of ALK positive patients, and you were randomized to a slightly old-fashioned and toxic chemotherapy regime plus or minus atezolizumab, which is a PD-L1 inhibitor. And they claimed that they showed a sort of non-statistically significant trend towards benefit. But in the final publication, that data magically disappeared. And I think the trouble is when you go down to a subgroup, you don't quite know that they're balanced in terms of other risk factors. So I would still say, show me the data. And I haven't seen anything that makes me think that's something you should rush to.
So, you know, you're, forgive the flattery here, but you're somewhat an international guru on ALK lung cancer, Ross. Natasha, you're an international general lung cancer guru. Ross, you know, you've got a lot of ALK patients in your practice. Do you ever prescribe immunotherapy to them?
The short answer is no.
No.
So we should be clear. So when we're talking about immunotherapy, you know, we're using that as a shorthand for this particular class of drugs called PD-1 or PD-L1.
Pembrolizumab, nivolumab, atezolizumab, durvalumab.
I would say no there. You know, it's funny because they're, you know, the ALK positive patient population, you know, many of whom are watching and listening, you know, are very smart, very motivated population. And they're saying, well, you know, why isn't it this for me? You know, if one wanted to be the devil's advocate, you could say, well, how would the ALK positive population act if suddenly somebody without an ALK inhibitor said, well, why can't I have electanib? You go, well, that's crazy. It's not going to work in you. It's the same kind of argument. This is a drug that for whatever reason doesn't work in ALK. But people are wondering if there are other ways of getting the immune system up and running, but that's all a work in progress.
Right. Okay. Natasha, so, you know, there's new ALK drugs. Instalment is the most recent one that from the World Lung Conference this year. Two questions then, two-part question. One, any comments about instalment? Should we be getting excited about that, or is it just another variety of cornflakes that is not better than what we've already got? And secondly, what do you see on the horizon? Are there new drugs that you could give us a sneak preview of, or that your spidey sense is tingling that is going to be the next thing?
Thanks, Paul. So, you know, cornflakes are delicious, and the study, the EXALT-3 study, is a very exciting study because it's like the sixth treatment that is out there now. It's also better than crazotinib, like electanib and brigatinib and lorlatinib.
EXALT-3, for those listening, that's the instalment study.
Thank you.
Yeah.
But it is a challenge because if you've got all these drugs that are better than the very first drug, well, that's great, but how do we pick among them? So again, cornflakes are delicious. I don't want to suggest it's just another bowl of cornflakes. It's a great new drug. And it might be, you know, that we learn in time that different people should be streamed towards these other, for example, these other 4 more advanced generation drugs. I do think that there is some interest in immunotherapy. It's not ready for prime time yet, but there's a lot of excitement. For example, Justin Gaynor's team and other teams are looking to see whether they can look at somebody's ALK-positive tumor, take out the immune fighting, so the immune cells, or what we call the T cells, or the potentially cancer fighting cells, grow those outside the person's body, and then give them back to see if they attack the cancer. So cell therapy or T cell therapy. So, there are a number of groups that are working on that. No real reports of activity yet, but definitely exciting. Mark Awad in Boston, Dr. Mark Awad is working on a vaccine to try and make the cancer more inflamed. So maybe these drugs that don't work, as Dr. Camidge has pointed out, might work in this more inflamed cancer. But again, that needs to be proven. And of course, this question of a combination with chemotherapy and other agents, such as the Empower 150 study, could be helpful. The other, question I think somebody's asked in the chat is, well, just because I've had some ALK inhibitors and they don't work anymore, and maybe I have or haven't had chemotherapy, can I go back or can I go to another class? And so the ALK Master Protocol is a very interesting study where they're trying to pick people based on new mutations in their cancer and stream them towards specific drugs to see whether or not a re-challenge of an ALK inhibitor or a different ALK inhibitor can help. So I think that's potentially very interesting. Especially after chemotherapy, you kind of get the sense that the body gets a reset and the cancer gets a reset, and that maybe re-challenge could be helpful. So that's one group of studies that are going forward. And then also combinations. We're learning that it's not just, the cancer is not just being driven through ALK anymore, but there might be other things. And so can you add a drug? And so there are a number of studies ongoing looking at that. Am I super excited about SHP2 inhibitors or MEK inhibitors or VEGF inhibitors? It's really hard at this point to choose. But I do think that, enrolling in studies remains very exciting. That there are some novel ALK inhibitors being developed, particularly in Asia. The drugs like repotrectinib and others that really seem to be emerging more in the ROS1 positive space than the ALK space. But again, we'll need to wait and see. Ross, what about you? What's really exciting you as the next great thing in ALK-positive lung cancer?
Well, so you have to, I think the answer is threefold, because the 3 is a good number. So the first is this whole idea about, nearly 50% of the slice of the pie post brigatinib, lorlatinib is not due to an ALK mutation. So defining how we identify these second drivers and making rational choice of combination is one area. The second area is, you touched on it, sometimes you can get these compound mutations, so more than one ALK resistance mutation in the same gene at the same time. And the more you do that, the more you change the shape of the molecule, and it's harder for your standard drug to fit in. So some people are developing drugs. There's a couple of companies that work on some of these compound mutations, which are admittedly, I think, relatively rare. The more we start on these next generation drugs, the less we're going to see compound mutations. And then finally, it's to kind of look at our successes, but where we could even improve them. So lorlatinib is really good at G1202R. That's a particular resistance mutation. It's really good at getting into the brain and covering the brain, but it has a whole bunch of side effects, some of which are due to the fact that it hits another pathway called NTRK. And so some people are saying, well, can we make a lorlatinib without NTRK activity? Can we make a drug that's as good but less yucky to take? And so some of those are just like, everything that we think is like, this is the latest and greatest, is really just version 1.0 of the next research project.
What do you think about Natasha's comments about cell therapy techniques?
Show me the data.
Okay, so research, but not prime time yet.
Yeah. They're all works in progress. I think it's very important this work goes on.
Yeah.
I think, I think one would be very interested in seeing what's going on. So you mentioned the vaccine. So one of the things that's actually been described in the lymphoma literature is that there are people who wander around with ALK-positive lymphoma who have anti-ALK antibodies. And we can actually find them in lung cancer. We published on that more than a decade ago. The trouble is we don't know that it matters. This isn't, we think antibodies and COVID and it's going to, immunity. These may just be what they call epiphenomena. It's just kind of noise. And so we have to say it's not just enough that we can measure an immune response. It has to be an immune response that matters in terms of an anti-cancer activity.
Okay. We're going to be getting close to the 6:45 time when we're going to start with some questions. So I'm just to sort of wrap up this section. You've gone through an awful lot of information here. It's terrific. I'm going to ask you to project for the next 10 years, so that we're sitting down in 2030, and what do you think we might see at that point? Will ALK lung cancer be a chronic disease at that point? What are your hopes for the next decade? And Natasha, let's start with you.
Thanks. So I actually think it already is for many people a chronic disease. I mean, unfortunately, not all of our patients have that great outcome, but so many do. You know, we see people every day that are living 7, 8, 9, 10, 12 years, right? It's getting much more common. I guess what I want to see, you know, what I'm hoping by 2030 is that this kind of smoking related lung cancer no longer dwarfs the whole spectrum. And we can really focus in on people with ALK positive lung cancer. It will be, you know, much more, because it represents more of what we see. We'll be able to expend more resources on it. So how do we find it earlier? How do we figure out why someone gets it and predict that? And then how do we use these ALK inhibitors earlier to really help with cure? I'm also really hoping that we understand better who needs to start with what, like who needs lorlatinib, who could have crazotinib, and then, you know, 3 or 4 other pills down the line over a 20-year period, who needs chemotherapy first, and, you know, when do we use radiation or surgery or something else? And then I actually do think, just based on some early data, not in ALK positive lung cancer, but other never smoking lung cancer, that immune therapy will play a role. So again, who is that? Who are those people where the immune system can be harnessed to cure? And then also, you know, as we're figuring things out, easier ways, right? No more biopsies. Can it be liquid biopsy? Can it be a scan? And can we do things before the cancer actually grows? Can we pick it up before somebody presents with back pain or a cough? Ross, over to you.
You were giving me too many things there to write down. Liquid biopsies, many people it's already almost a chronic disease, figuring out which drug for which person more accurately, using it in earlier stage diseases as a cure or to support a cure. There's a lot there. Okay, Ross.
Well, Natasha did a great job there. So you know, I gotta try and add something to the party here. So wouldn't it be wonderful if, given that we know that an ALK gene rearrangement shouldn't exist in your normal body, it is a completely foreign construct between these two genes that should be perfect for early detection. If we could somehow dial up the sensitivity, you know, you go to the supermarket and, you know, there was that movie Gattaca where, you know, everyone was always checking your DNA all the time. And so you'd go through the checkout and it would go, hold on, you know, you've got an EML4 ALK in your breath, you know, that I can detect, go get a CT scan. So I think early detection, personalized, not just to lung cancer, but to some of these abnormalities might come in. That would be great. Then let's say, you know, it does turn up. I think our ability to detect minimal residual disease, even when you think you've done surgery or radiation or something, will be important to say, look, this guy's not cured. We need to go do something else. I think Natasha hit the nail on the head. You know, even within ALK, there are going to be subgroups. There are going to be higher risk groups and lower risk groups that maybe will say, this one's hardwired to go this way in terms of resistance and might influence the drugs. And then my favorite elephant in the room is the fact that if I put somebody on an ALK inhibitor, they'll have an amazing response. Maybe their scan will look normal. But if I stop the drug, even though it's years before their cancer will grow, something will start to reemerge within weeks. So there is a fraction of the cells which are still sensitive to the drug, but not killed. And so that molecular persistent state, which is incredibly hard to study because it's microscopic, is what we need to identify, because if we can purge that, we go from 99% cell kill to 100, and that's a cure. And very recently, between ourselves and University of California, San Francisco, we did some early rebiopsy studies, and we're starting to find some of the signatures, and they really are kind of like, you know, not the things you're used to looking for. They're just kind of, you know, little survival pathways which are induced within minutes that maybe we can purge.
That is very cool. For those who, Gattaca, Ethan Hawke and Uma Thurman, I think, if I remember well.
Yeah, well, and Jude Law.
And Jude Law. I didn't love that movie, but interesting about this, yeah, they would detect your DNA anywhere. The breath you mentioned there, Ross, you know, the idea of detecting something in the breath, that science is going on right now in Canada. And the first, just a shout out to Lung Cancer Canada, because that's what I should be doing. But the first Jeff Ogram Memorial Research Fund award, which is our biggest research award that we give, went to a group in Vancouver last year studying this science of breathomics, trying to get early detection of lung cancer from the breath. Super cool. Right. So thanks, Ross and Natasha. We've covered an awful lot there. I'm now going to hand over the chair of this, and I'm going to sort of join you on the panel as the weak member, the weakest link. I'm going to pass this over to Christina, who's going to go through some of the questions that have come in.
Thank you so much to our esteemed panel. There actually has been a lot of questions, and I completely agree with you, Dr. Camidge, when you say that this group is very motivated and very astute in terms of their questions and their knowledge. I'm going to start with a couple of the basic questions first, and then we'll move on. Question, maybe we'll start with Dr. Wheatley-Price. What percentage?
Basic question.
Sorry?
For the basic question, that's good.
Mr. President, what fraction of lung cancer exhibit the ALK+ mutation, and how can learning about these sort of mutations help us in treating cancers that do not exhibit mutations in terms of understanding how cancer really works?
So the first part of that is it's around 3 or 4% of lung cancers are ALK positive, and they are restricted to what we call the non-squamous population. So if you think lung cancer as a whole, there's two broad categories: small cell lung cancer, which is about 12 to 15%, and non-small cell lung cancer, which is about 85% and isn't small cell lung cancer, and it's a silly name. My dog George is a dog. He's not a non-cat. But anyway, non-small cell lung cancer, that is the bulk, and about 3/4, 2/3 of them are what we call adenocarcinoma, and that's where we find the ALK. So ALK is probably 3 to 4% of all of them. And the second part was, how does ALK help us learn more generally? Well, I won't go into much detail about that. I think you've heard from Ross and Natasha that that ALK was the second of these what we call oncogenic driven lung cancers, EGFR being the first that we covered last month, ALK being the second. But this has driven discovery and research so now through more analysis of the genetic makeup of the cancer cell, and we might talk at some point about next generation sequencing testing, which will be one test which can detect a bunch of these things. We can now detect multiple different subtypes of lung cancer, and you've heard some of them mentioned: EGFR, ALK, ROS1, MTRK was mentioned, CMET, exon 14, SKIP, RET fusion, BRAF, KRAS. There's a number of them now, and ALK has helped drive that science forward.
And so the next question I'm going to pose to you as well, because it's a question of your making within the webinar. And one of the audience members just asks how a drug can be available in one city in Ontario, but not in another.
Well, so the example that I was giving there was research studies. So generally, once Health Canada has approved a drug, it's in theory available across the country to be prescribed by a physician with a license. The challenge is getting it paid for, and that has to go through the health technology process and then back to each province to put it on their formulary and cover it. if it's not gone through that process yet, then, you know, and Dr. Leighl mentioned maybe through private insurance, through compassionate access programs, or through clinical trials. And so, you know, lots of academic centers have a number of trials running, but we don't all have the same studies. There's too many studies going on in the world for us to run all of them in one center. So, you know, we work in collaboration with each other. I've had one of my ALK patients who went to Boston, for example, to look at a clinical trial there.
And so basically, it's just that all the researchers and the clinicians tend to help each other out and really share the knowledge and share the resources that they have. So I'm going to
and I should just say that can work across provincial borders as well. So you know, also we're right on the border with Quebec. We have Quebec patients who can come to us for clinical trials too, and vice versa.
So before I go on with the question and answer, I know many of the ALK patients and the ROS patients are watching tonight, and thank you for joining us. There's many questions that did come in on about your personal situation, and unfortunately we cannot give medical advice within this session, but I will try to generalize some of the questions so that they can be answered. The next question I'm going to shout out to Dr. Leighl, and is there any similarities of ALK between ALK and MET?
So what's interesting, you know, as you know, crazotinib is a drug that targets ALK, ROS, and MET, and so, you know, those sort of three have come together. But we have learned that similar to people with EGFR mutant lung cancer, MET is important. And for people with ALK-positive lung cancer, there's a group of people that when the ALK inhibitor stops working, it's really because of MET. And so, you know, we, for example, with Dr. Jeff Liu and our team, we actually took a sample of a patient's cancer, we grew it in the lab, and we realized that the reason why it was growing was because now it was addicted to MET, not so much ALK. And so, you know, can we add these drugs? And so that's, you know, part of this concept of, you know, if things have stopped working, biologically why, and then how do we make sure we target all the pathways that are important to that patient's cancer. So MET is actually important, and I think we're still learning about how important and how to find people that could benefit from some sort of combined therapy. Perhaps these are people that could even go back on crazotinib, right? You know, we'll have to see.
So Dr. Leighl, you have lots of fans that are here tonight, and there are some questions that came in through email and in the chat that were directed to you about your testing and your liquid biopsy project, and they wanted to see if you could provide an update.
Well, thank you. So, you know, I think for the Canadian system, liquid biopsy is a real boon. You know, we often get these results faster, they're easier in patients, you don't have to wait for the biopsy, sometimes even the profiling results is faster, and it's so much easier in patients, right? You get everybody on the call tonight, you get blood almost every month or every couple of months, and wouldn't it be great if we could just add another test onto that rather than actually doing a tumor biopsy. So we have been working on, and Dr. Wheatley-Price has been part of this, thank you so much. We've been working on a project where we're trying to get liquid biopsy paid for, or trying to show the value in people that have been on targeted therapy like ALK inhibitors and then it's worn off, or people who are newly diagnosed with lung cancer to try and find things like ALK rearrangements faster than we normally would. So that's where we are currently. You know, liquid biopsy is very exciting. It can be used for a lot of things. It can be used as part of diagnosis. It can be used to figure out why a treatment's not working or part of resistance. And it could be used for monitoring, you know, so if you start your ALK inhibitor and your levels of DNA or genetic material in the blood go down, then that therapy is working. Now in Canada, you know, we ask you how you're feeling, you say you're feeling well, and or you're feeling better, and that's how we know the drug is working, or we do an x-ray or a scan. But, you know, liquid biopsy potentially could find that earlier, or when it's not working, you know, the levels either stay the same or they could go up. And so actually the instalment trial that Dr. Wheatley-Price had talked about earlier, the EXACT-3 trial, they actually showed that you could use liquid biopsy to figure out when it's going to work and when it's not, who's going to do better on treatment for longer. And maybe this is a way in time we could learn to kind of figure out who needs to go on what, when. Sadly, not yet ready for prime time, but I did see somebody's name in the chat, and I'm happy to talk to you when I see you again about liquid biopsy and whether we can have a new creative approach for you.
Perfect. And so there might be a day when you're all the patients that come in, they're able to take their blood, and just like HIV, you can see do a readout of your tumor, and then we're just going to personalize your treatment based on what your tumor looks like. And so I'm going to go across to another country and turn it over to Dr. Camidge. Dr. Camidge, can you tell us a little bit about the research that's ongoing about delaying resistance or prevention to resistance?
Yeah, so I mean, there are certain commonalities across lots of different oncogene-driven lung cancers at present, and it's kind of like a retro move. So a lot of people are looking about saying, okay, you're starting on these TKIs, these oral inhibitors, whether they're ALK or ROS or EGFR. What if we give you a course of chemotherapy at the beginning? And you go, well, chemo, that's the stuff we try and put off. No, this is a defined course, because there have been a couple of studies, one from Japan, one from India, in EGFR mutant lung cancer, showing that, you know, maybe that's a way of getting rid of some of these persisting cells and, you know, and prolonging outcomes. People are talking about doing those kind of studies in ALK. The other area, again, you know, not on a molecular level, just to kind of, you know, something to add to everyone, is adding in an anti-angiogenic. The trouble with all of these studies is, you know, it's very palatable to just say, I'm going to go on a pill. It's somewhat unpalatable to say, and you thought you dodged chemotherapy, you dodged intravenous infusions, but no, we're going to, you know, include them there. But those studies are going to go on if they're completely transformative in terms of the outcome. And by that, I mean overall survival, not just that time to the next treatment decision. Remember, we're talking about years of life, not just, you know, what happens in the next, you know, 1 or 2 years. You know, we'll have to wait and see whether that's going to be a value-based judgment.
Ross, can I ask you just to explain what anti-angiogenics are?
Oh yes, I'm sorry. I was trying not to lapse into medical speak, but they are antibodies that work on blood vessels. And like an army needs its supply line, a growing cancer needs a blood vessel supply. And some of these, and there are different pathways that can turn on and off blood vessels. And some of the drugs which have names like Avastin or Cyramza, or to give them their proper names, bevacizumab and ramucirumab, can interfere with at least one of those pathways.
So there are also some questions, Dr. Camidge, about vaccines. So maybe I can ask you to give a rapid answer on that as we're coming up to the hour. Okay,
so the question is, you know, so what Mark Awad and others are doing is, you know, recognizing that there are antibodies floating around in people. You know, the ALK fusion is inherently foreign. You know, could you take that bit of foreignness and, you know, inject it in someone and make them make more antibodies or cell-based immunity either? There are two challenges. One is, just because you have the immune response doesn't mean it's a useful one. The second one is that when you already have an established cancer, it's hard for the kind of vaccinations really to get a grip. I mean, it would be great if, you know, maybe you had somebody who'd had an early stage ALK cancer removed, and then you were giving a vaccine in when there's minimal disease. You know, that's where vaccines have traditionally triumphed. So it's all somewhat experimental, and I would say this to Mark's face, you know, I'm somewhat skeptical as to whether that's really got legs.
So my last question of the night, I'm going to turn it back to Dr. Leighl, and it's about clinical trials. There's been lots of questions in the chat and the previous to this webinar about clinical trials and how Canadian patients can get involved, and what if you're not you're not from Ontario, but they see something open at PMH.
So I think, you know, trials are so important, and I think Dr. Camidge and Dr. West many years ago wrote a piece that said something like, you know, how the biomarker will travel, which I think really encapsulate the fact that people are so motivated to go to a center that has the treatment that they need. So I mean, what I recommend to patients is, you know, get familiar with cancertrials.gov. You can call the number. Go to Lung Cancer Canada. You guys, on your website, you guys have a list of active clinical trials for people with lung cancer. And also, I'm sure if somebody emails you, you would help them look for that. And ask your oncologist. So, you know, sometimes I'll have someone say to me, well, look, what are the other trials out there? And I will. I'll go on a website and look for different trials. And then we can refer you, or we can share information. And especially now during COVID, we're doing a lot more virtual care. So for example, I see people virtually from other provinces. We go through the trial, we talk about how they are, we kind of do what we call our screening to see if you're a candidate to join the trial. We can do a lot of that without you even having to travel. And so, you know, unfortunately, eventually you probably do have to travel, you probably do have to go to that center. But oftentimes, you know, the person who's sponsoring the trial, what we call the trial sponsor, the person who's paying for it, often these are drug manufacturers or pharmaceutical companies, and they will often pay some of your expenses, travel expenses, some of the expenses to stay or go back and forth. And so we often try and do that to help support people that are coming from other provinces. You know, during COVID, we've actually repatriated patients from the US. We have a patient that was getting treated in New York, and we've relocated him here. He's actually from Montreal. We talk to patients in Calgary. We have patients from BC, from all over. Very lucky to have met some patients of Dr. Wheatley-Price's that we're hoping to help out. So really ask your oncologist. You know, I think we want the best possible treatment for you. And I think, you know, certainly everyone attached to Lung Cancer Canada, none of us mind if that best treatment isn't at our center. We want to get it for you, you know, wherever it is, we want to get you there.
The important thing is just to make sure you ask the questions and talk to your medical team. So there were so many questions tonight, and I know that we couldn't possibly get to them all. There were some other questions about ROS and other mutations as well. And I just wanted to say thank you to our panelists for taking the time out tonight. And thank you to our moderator, Dr. Wheatley-Price, for giving us the time tonight and really making sure that not only do we stay on time, but all the discussion was kept to a level that patients can understand. This series was born out of because of you and because of your suggestions of what you wanted. And we will continue to do these What's New in series. We have some lined up in the rare mutations as well as immuno-oncology. Stay tuned for them next year. They're going to come out in early 2020. But I want to tell all the lung cancer patients listening in today that really there is hope. I'm going to give a shout out to my friend Anne-Marie Serrato, who has celebrated her 11th year cancerversary living with ALK+ lung cancer, and many of you as well who are celebrating cancerversaries. And those are that are beginning your journey. Please do not give up hope. And for everyone here that's listening tonight, if you believe that lung cancer patients deserve more of a voice, and if you believe that lung cancer patients really deserve the access to treatment, then please help us and join Hope Army. Visit lungcancercanada.ca, join Hope Army, sign up, and really help us increase the share of voice of lung cancer patients and their issues through your social media channels. So thank you everyone for your time tonight, and we really wish you a pleasant evening, and please join us for our next webinar series.
My name is Diane Van Keulen, and I was diagnosed on March 28, 2019 with stage 4 lung cancer. Hope to me means never giving up, thinking to the future, and knowing that God has a purpose for me, and He will lead me in the direction I need to go. Hope is always believing that my medical team knows what's best for me and will work their hardest on my behalf. So as long as I have hope, I have everything.
Thank you.